All right, so we've got this beautiful dissection that Dr. Trinan has done of the anterior and medial thigh. So why don't we just take a little walk through and see what we can see. The first thing I'd notice right offhand, we've got this beautiful pes anserine attachment here on the anterior medial thigh. We could see very nicely how sartorius feeds into it, as well as the gracilis. We can't see the semitendinosus from this view. The other thing to appreciate is that she's already removed the fascia lata to be able to see our muscles here very quickly. Very cleanly, but she's trimmed here so that the thickest part of the fascia lata, the iliotibial band, is still present, and she's pulling that back with her thumb. If you do take some time to get into the cadaver lab, really appreciate how the IT band spreads itself out across the knee in these beautiful different sort of combinations of fascial layers, and all of these are going to have some sort of complex mechanical influences on the knee. You'll also notice as we dive in deeper here, she's done a nice job of removing some of the fascia lata so that we can clearly see the tensor fascia lata muscle. Nice tensor fascia lata. So this is nice right here where her thumb is. What we can see is this is probably some posterolateral fibers of the superior gluteal nerve coming in from behind to innervate tensor fascia lata. So that's really pretty. You can see very nicely how sartorius and rectus are heading towards the ASIS. The other thing, let me see if I can back this up here a little bit. The other thing that you could look at here, so she's on the ASIS, and we said if you come a couple inches down the inguinal ligament from the ASIS and then come onto the thigh, probably right about in here is where I would expect the lateral femoral cutaneous nerve to have surfaced. Some lateral femoral cutaneous nerves, as soon as they get beyond this inguinal ligament, will go up and pass the fascia lata to get to the skin. This was probably one of those. Other ones that you might see on cadavers, they sort of stay below the fascia lata for a ways before they come out to the surface. But this would be the area that you would look in as a clinician and push on if you suspected there was some compression on that nerve. So now that she's lifted up the sartorius, we can see down into the subsartorial or adductor canal. We're seeing right in here a lot of muscular branches of femoral nerve hitting the sartorius from deep. You're going to have some branches hitting the rectus femoris in here. Probably right about in here and right about in here, we would have the saphenous nerve, right, which is going to pass through the subsartorial canal to get down below the knee to service the medial part of the leg for skin cutaneous input. And then we probably have in here some of the nerves to vastus medialis. Can see here's a bit of the femoral artery. Femoral vein is going to be just right here. We'll see more of it. Now this guy right here, this might be just the edge of the profunda femoris. You could see how it's right here. It's sort of diving deep and we can't see it any longer. But this is probably a bit of profunda femoris. Have a nice rectus femoris here. And as she pulls it laterally, we can see here big sort of a common aponeurosis, a central tendon for the vastus intermedius. This is all vastus intermedius here. This right here is the medial edge to vastus lateralis, which continues way down here. A lot of people think of vastus lateralis, right? Like in runners, you could see it. It's very defined, but it really attaches way up on the femur. We've got some nice muscular branches of femoral nerve right in here that are hitting the intermedius as well as coming out here to vastus lateralis. So as we pull sartorius back, right, look at all of these beautiful muscular branches of femoral nerve. The femoral nerve is not part of the femoral sheath, but Dr. Trinan's done a very nice job of cleaning the sheath off to reveal the femoral artery and the femoral vein. I think this is probably the edge of the sheath here. We've got a bit more of the sheath right in here. She's cleaned some of this up. Typically, this is kind of a big pocket for lymph nodes, right? You think of if you've ever been sick, you can get some inflammation in here, and your groin or the area of the inguinal ligament can get sore for you. We've got a very nice adductor longus here. We can see this is part of the anterior branch of obturator nerve coming out to service motor function for gracilis muscle. If we were to look deep in here, deep beneath these lymph nodes, pectineus would be located in here. So lifting up adductor longus, beautiful. Look at this anterior branch of obturator, right? There's going to be some other branches in here as well. And all of this muscle in here deep, this is all adductor brevis. So we've got gracilis. Very nice. And then if we pull gracilis medial, now we can see the most medial edge here to the adductor magnus. That's very nice. Keep pulling it back. And one thing that I like about this view, you can see how the hamstring or extensor portion of adductor magnus becomes more tendinous as we get down here closer to the femur. So let's say the edge of the femur is probably right along something like this. And we can clearly see how the hamstring or extensor portion is tacking itself down onto the adductor tubercle. Right about in here is probably the edge of the hamstring portion, and probably about in here is where the main portion of adductor magnus is. So we're pretty close in this region in here to where the adductor hiatus would be. If we looked more medial, we could probably see the femoral artery and vein passing in through there. All right, that's a pretty dissection. Thank you, Dr. Trinan.